So we're gonna record this event. It's a CME, and it's gonna be in my YouTube. Hopefully, I will do it today. So yeah, I'm Dr. Halas. I'm the founder of Chronic Disease Prevention Management. And yes, we're trying to get this chronic disease prevention management, a PhD degree in it, maybe an official board specialty. We already have the CME from American Medical Association. We have fellowships, and we have also international presence. And if you go ahead and see that I traveled to Germany and I have a group of doctors, I train them to load drugs inside platelets nanoparticles. And those group, they do plasmapheresis, by the way. So, so there is some sense of humor in the Germans, although it's not common for the Germans to have sense of humor. But yeah, with Americans, they end up opening up with us. Um, so they are working with us, and we have many potentials with other international clinics and centers. If we join forces together and really put our hands together, we can have a center in each state, in each country. That's the plan, especially with this meeting with Dr. Jenny and Dr. Dalal and with Strive and all this, pioneers here in this room. We can join forces and we can start writing books as well together, especially with artificial intelligence, makes writing the book easy for us. And I have editors, Mr. Sheldon and Jeremy. They are editors. They will help us in getting those books on the board. Maha book is coming out. We can use also Dr. Dalal together, those two books, and see if we can get RFK and Trump interested in what's the mission in the book. But we can write books together. We can co-author, and that's the plan. I have a big textbook of chronic disease prevention management. It's ready. It's ready to go. We can have as much as co-authors. All of you can be co-author in the book. That will be kind of the Bible for our field of medicine of chronic disease prevention management, and it include everything, include the mainstream medicine protocols. It include all the integrative medicine, regenerative medicine, holistic, name it, everything in both sides of the aisle, integrated in a way it makes more sense, avoiding the extremes from both sides of the aisle. And this is my biography. I think everybody, it's in the screen here. So what's the chronic disease prevention and management it's all about? Of course, we want to create, we already have a fellowship program and we have the CME recognized by American Medical Association. But the field is focusing on diagnostic and therapeutic techniques to empower healthcare professions to modulate their patients' immune, redox, metabolic, and regenerative conditions. So that is the definition of this field. It's a new medical specialty that focuses on developing diagnostic and therapeutic protocols that leads to modulation of redox, metabolic, regenerative, and immune status. Now, everybody here in this room, they're very good in modulating the metabolic status of the patients with your sex hormone and replenishing all the deficiency of the nutrition and the vitamins, and also very good in detoxing by taking care of the leaky gut or using the IV detox to detox heavy metals or fat soluble toxins. Um, so we're very good in this field. And regenerative, we're doing exosomes and the platelets and things that we have. But when it comes into immune modulation, this field of medicine, it's a new. And we did not study it at medical school when we were in the medical school because in 2002, there is no TH17 and Treg. They all know is about TH1 and TH2 because I worked with Dr. Uh, Frank Arson in Baylor College. He is an immunologist, and I worked in his lab. And basically, what he does, he's treating allergies, and how he treats allergies. Well, he said, instead of just masking the problem by giving them antihistamines, this is just the mainstream medicine approach, is blocking the histamine receptors, right, by using Benadryl and all that stuff. cetirizine. Why we don't go to the root cause and trying to manage the allergy and the imbalance of the immune system from the root instead of just masking it from Benadryl and make those patients insensitive to, let's say, peanut butter. People have allergy to peanut butter. So what he does, okay, he said, well, the whole problem with people with allergies that when they encounter the allergens, their immune system kind of skew or overshift into Th2. And that leads to hyperinflammation and producing of immunoglobulin E and allergy. So because of that, that's the root cause. That's the abnormality. Is that when they take allergens, your macrophage eats the allergens, and they don't produce balanced immune response. Balanced immune response, they're supposed to give you some M1, some M2. No, they give you more M2, and then M2, which is the macrophage type 2, they start secreting all those interleukin 4, which cause the polarization of the helper T cells into Th2, and then Th2 would start secreting more of interleukin 4, which leads to the immunoglobulin
Hey,
shift to
Dr.
immunoglobulin E.
Halasa, I'm sorry to interrupt. I'm really sorry. I think they're saying that nobody can see your screen. Would it be possible? I'm sorry to interrupt. I really
Oh,
am.
no problem. No, no, you don't see my screen?
Nobody does, and I just want to make sure that we don't
Okay,
miss
okay,
we don't miss this amazing topic.
okay. Let me go ahead and can you see my screen now? All right. Let's do
Yes, we can see it now.
let's do the stop sharing and then do the share screen again. Okay. Um, Stop sharing and then do the share again and make sure we put the voice. Okay. And optimize the sharing. All right. And then share. Okay. Now, can you see my screen? Can you see my screen?
Yeah.
Okay,
Yes,
good. So, um, so what, so he told me, okay, well, what he does, he's trying now to come up with the protocols to shift the immune system from Th2 to Th1. So how he will do that? Well, if you encounter allergens, protein from eating the peanut butter, the allergens will be taken by the macrophages from the gut macrophages because you eat peanut butter, and then the protein will be taken by the gut macrophages, and then the macrophage the naive macrophage will polarize into M2, and then M2 will start secreting too much of interleukin 4 and polarize the naive T cells into Th2, and you end up with a hyper immune response of Th2, and then Th2 will start secreting more of interleukin 4, which will lead to the immunoglobulins B cells to produce more of IgE, and then the patient would have allergy, right? And you end up with activation of mast cells and all the allergic reactions in the form of hives, swelling, or in the form of diarrhea. Some of the patients of allergy, they came up with diarrhea, right? Because you end up with too much of histamine in the gut, and histamine is contracting the guts, and you end up with manifest as diarrhea, or you end up with, as I said, those um, um, wheals in the skin and redness and swelling and hypertension. So what they do, they give them cortisone, they give them epinephrine shot, and they give them antihistamines, and also this is what the mainstream medicine does. Well, Dr. Arson Frank, he said, well, if the whole problem is the immune system shifting too much abnormally into Th2, why we don't just shift them back to Th1? So how we would do it? Well, it's for the macrophage. If they eat the protein from outside, they polarize into Th2, too much Th2. But if they eat the macrophages, the protein, and it's expressed inside the macrophage. So protein from outside, they end up with hyperpolarizing into Th2 and M2. But if those proteins being expressed inside the macrophages, think about macrophages are the eaters, and they are tasting food, and then they determine where the directions the immune system will be. If the macrophage eats the DNA, of the bacteria that express the peanut butter protein, and the protein of the peanut butter is expressed inside the macrophages, then the macrophage will respond differently. They will polarize into M1 and into Th1, and then the cytokines of the Th1, which is interleukin 2 and 12, they will inhibit the polarization to Th2 and give you that balanced immune system and preventing the hyperinflammation mediated by Th2 and immunoglobulin E. So the idea is why we don't just go ahead and shift the immune system into Th1. And that cytokines of Th1 will inhibit the cytokines or polarization of Th2 and give you that balanced immune response and desensitize the patients. That is the whole idea. That's the whole concept here. So what he does, he takes the macrophages, he takes the monocytes from the blood, and he treats the monocytes in the lab to be differentiate into dendritic cells. With chemicals, or you can use platelets, the factors, by the way, and they will incubate them, and they turn into dendritic cells. And then he feeds the dendritic cells with plasmids of bacteria that express the peanut butter proteins. Okay, that's in vitro. And then he takes those macrophages back and inject them into the body, whether IV or subcutaneous. And that leads to desensitization of the patient because those macrophages, when they encounter when they, or the immune system, because you have a lot of memories now of Th1, right? When they encounter the protein, they produce both Th1 and Th2 in a balanced way, and one is canceling the other and preventing this hyperpolarization of Th2. So that's the idea. So the macrophages, when they are the proteins of allergens being expressed inside them, they tend to polarize into Th1. And that's what the macrophage does in general. When they eat the virus and cancer or intracellular bacteria, they tend to polarize into M1 and Th1 and cytotoxic T cells, which is very critical, especially for the virus. If you want to get rid from those infected cells with viruses, then you need to have enough of Th1 and cytotoxic T cells to clear those infected cells with those viruses. And you need to polarize the immune system to Th1. And that's what the macrophage does. When they eat viruses, cancer, they tend to move into Th1. So what happened is that, let's go back to my work with Dr. Arsa. And I told him, well, why we don't do this? And instead of you taking those dendritic cells, injecting them subcutaneous or giving them IV, and why we don't take the plasmid and load them inside the red blood cells and then inject the red blood cells with the bacteria plasmid that express the peanut butter, inject into the blood, and those red blood cells eventually they will be taken by the spleen of the macrophages, engulf them, and they will be expressed there, and that will lead to shifting into Th1. He liked the idea. He said, well, that's better than in vitro work of taking monocytes and then treat them to become dendritic cells and feed them with the plasmid and putting them down the body. Well, this is more easy because it's just all you need is just loading the plasma with the red blood cells and just inject it into the body. It just shorten up the whole process and it make it more natural. So I went and I joined his lab. This is like 2002 or 3. And at that time, there is no Tregs, Th17, they only have Th1 and Th2, M1, M2. They don't have Tregs and Th17 and all these things. At that time, it's not yet. The whole thing is just learning how to shift things in from Th2. And Th2 and M2 means also Treg. And Th and M1 it can be polarized the immune system to Th17 or Th1. But that time they don't know Th17. They only know Th1 and Th2. And but still the concept is there and it's valid, the whole process, even if the knowledge is not there. This is talking about 2003 and 4, by the way. So I joined him and in Baylor College in his immunotherapy lab. And instead of seeing patients, which I used to be in when I came from Libya, I'd be seeing rats because I was doing my USMLE at that time, yeah, my exam. And in the morning, every morning, I go downstairs to the basement. They have a lot of rats, and I go and take the rats, and I learn how to take blood from the tail, and then I spin it, get the red blood cells, not platelets at that time. I don't know about platelets, red blood cells, and then I take the plasmid, and I'm trying with the vortex to mix them together. The problem is the whole technique that I'm using, it's just immature or it's not fine process. So I'm getting some loading of red blood cells because I have fluoroscopy and I can see it, but I have a lot of hemolysis. And that's not good. If you have hemolysis, then if you start injecting people with blood that's broken and you have hemolysis, you end up with hemoglobin toxicity and all the hemosiderin, all that stuff, and iron poison, all that stuff. So the whole program, I spent 6 months, but I did not really conclude the whole thing. The reason because the plasma is too big and it's poking the red blood cells and it's destroying it. Now you can do loading red blood cells with drugs by little vortex there and by diffusion that work. You can load them with cortisone. You can load them with all the smaller molecule. That's fine and it works very well. But if you and there's a lot of publications on that. But when it comes into big molecules like plasmid and RNA, it failed. So the whole thing failed and I moved on. And I start working with pain management with a group of doctors in Delaware. It's called Compassionate Pain Management as a physician associate while I'm doing my board exams and all that. And I learned a lot from that practice, a lot, because the head of that practice, she was very innovative and she's not just masking the pain, but also she's looking for the root cause. Her name is Dr. Eva Dickinson. She's a very intelligent doctor, by the way. And I learned a lot from her, and we really did a lot of good job. We end up expanding 3 medical centers, and we have another word. All the patients are start moving to us, and you end up doing that. You irritate some other specialists. So I don't want to go detail there, but we have very big operation. Um, and then I end up with a company it's called Nitro Medicine because I did a lot of laser therapy treating patient with complex regional pain syndrome, which is one of the difficult pain to treat. I mean, complex regional pain syndrome is like the failure and failure. There's no really hard to find somebody to manage it because they have the central pain and very sensitive, and you cannot inject them, and you cannot do much with them. Even thinking that you're going to examine them, they will flare up, and they just hate doctors and they live inside the bubble of narcotics. And yes, you end up with neuroplastic change of the brain where they lose all the interest of anything except seeking the narcotics. That's the only thing that their brain circuit is working with all the hyperplasia and progressive neuroplasticity and that area of pain and seeking drugs. Um, and that's what we call the neuroplasticity, which is similar things to Dr. Jenny. She's talking about drugs when, especially narcotics. Yes, they help in pain, but at the same time, they induce oxidative stress and inflammation, which will lead to abnormal neuroplastic change that will make the patients hooked into the drugs and seeking the drugs because that's the only rewarding that they can get and the only thing that increase their dopamine and the only drive of their life because all other circuits is being abolished by the inflammations and they cannot really create any other interest or hobbies except seeking drugs because it's very solid circuit and their life it's all about seeking drugs because that's the only thing that increases their dopamine. And so I'm just trying to say, Dr. Ginny on the same page here about those oxidative drugs, although they may symptomatically give you some relief, but at the same time, they may lead to abnormal side effects like we have in narcotics. And that's another topic. So, I end up treating patient with complex regional pain syndrome. You cannot really block this ganglion as we do because any injections they aggravate. And patient with, for example, they have one complex regional pain syndrome in his one arm, right? And if you try to cause any pain in other arm, like injecting or anything, it can transfer to the other arm. So you end up with two arms with complex regional pain syndrome, sweating, pain, they cannot move. It's just horrible. situation, and they're on the highest narcotics dose. So what I learned is to treat them with light therapy, and light helps to buffer the redox, increase the nitric oxide, and helps to also restore the neuroplasticity and manage the whole neuroplastic pain and allodynia and hyperalgesia. And that's what I did. So I start shooting them with light therapy first until I can touch them and examine them and then put some topical cream of nitroglycerin, alpha lipoic acid to do the, to induce vasodilations and buffer the redox and restore the neuroplasticity of both peripheral and central. But it takes a process. So light, then topical cream, then start weaning them from the narcotics, then give them sex hormone, then optimize their health until they completely become free after we optimize or restore the brain neuroplasticity, basically, especially the amygdala that's hypertrophic and with a abnormal progressive. Once you break those neuroplasticity and normalizing it with with health optimizations and with light therapy and sex hormone and all the health optimization that we do, restoring the metabolism, some eventually some exosomes and stem cells. We did everything, and I published an article that is in with Dr. Michael Hamblin from Harvard Medical School. It's been published, so if you click my name in Harvard Medical School website, you will see nitromedicine as a new medical specialty and showing that combining laser with nitric oxide with stem cells will help to regenerate and optimize the health of the body. So that's one of my publication there for light therapy. And then I end up with this chronic disease prevention and management. When COVID hit, I can see that there's a problem with those medical specialties. So I come up with this title, and coincidentally, I find out that the American Medical Association is doing the same thing, and they are also doing chronic disease prevention and management. Okay, and that's a good thing, right? Because, having two things, two group of people doing the same thing, and I have no clue about their doing it until I start searching and seeing anybody does the same thing, chronic disease prevention management, and I find out, yes, they are. Um, and who is doing it is American Medical Association. But what they did, this group of CDPM of the American, they redefine history and physical exam to include all the systems of the body. So it's not like specialists they focus on, oh, I only know about neurology. I don't know anything about cardiovascular or anything about diabetics. So go to your endocrinologist, go to your cardiovascular. And then the patient is getting lost among all those specialists and with a bag of drugs, and nobody's coordinating all these treatments. And AMA find out that it's a big problem, especially with coronavirus. It's multisystemic disease. You have cardiovascular, you have encephalopathy, you have aggravating your diabetes, and most of those patients are not well managed, especially the long COVID. And that's the reason I think this group came up and say, hey, doctor, physicians, you need to learn how to integratively manage the patient as a holistic and involve all the systems and looking all the biostatistics and all the stressors that aggravate the condition that you have, which may include and involve other systems of the body or external environment stressors, whether the work and job and toxins or whatever the patient's been exposed. And they came up with a very nice presentation of CDPM group redefining history physical exam. They call them HP 360. So I went farther and I say it's not just enough to redefine history and physical exam. We also need to redefine the way we diagnose and treat the patients. So I came up with the four pillars. In order to manage a patient with chronic disease, then you need to understand the pathophysiology that leads to abnormal redox and metabolic and immune regenerative status of the patient. And regenerative status include both degeneration and cancer, overgrowth. So regenerative status could be abnormal regeneration, which is cancer, or abnormal degeneration, which is the degenerative diseases. So that's under regenerative medicine. Cancer is under regenerative medicine because they abnormally regenerate. And degenerative disease, it's also under regenerative disorder because they abnormally degenerate. Aging is degenerative disease, by the way. And so I redefined the physical the treatment and diagnosis so that we can seek for all this abnormality, abnormal parameters, and all the abnormal markers of the redox and metabolic and immune regenerative, including the genomics, which Dr. Padalal came up with, redoxomic, metabolomic, right? You know, the genetics behind the abnormality of those metabolism and redox and regenerative and immuno, which is the genomics. Yes, that's part of those four pillars at all different level, whether it's at the enzyme level, it's being blocked, or a deficiency of the nutraceutical or the of for the enzymes or the cofactors, or it could be genetic abnormalities, epigenetics especially, and you need to find out how to activate them, and that would help to restore the metabolism or the redox balance or the immune or regenerative. So let's go ahead and watch what AMA is entertaining, redefining history physical exam, the 360, because that is the door for the whole field of medicine that we are trying to create a medical board for it. So it's only 5 minutes.
It's been known for decades that the biomedical picture is not the complete picture of the patient, and that became more and more clear as chronic diseases go undertreated or undermanaged.
60% of Americans have one chronic disease and 40% have more than two chronic diseases. And the traditional history and physical is really geared toward a single problem. And the HNP 360 allows us to really understand their chronic disease in the context of their social structure, their community structure, racial barriers that we need to consider if we're going to provide complete care for our patients.
So we have to find a way how to standardize it and actually come up with a tool to be able to collect their information in a strategic way. And the HNP 360 does exactly that.
Everywhere you want to take a picture of an entire patient and their life and their trajectory, these 7 areas pop up. They're both universal in that they apply to every patient in every context, and they're comprehensive.
It's a lot of information, but you don't have to use all of the domains all of the time. So you can kind of go and pick out the ones that are important.
These domains are flexible enough to allow assessment of these things that are so important to health, but in a very patient-centered way.
One of the domains that I really like is the patient values and goals domain, because it really helps me to understand where the patient is coming from.
Knowing that enables us to come up with a care plan that makes sense for them and is more likely to be executed well.
The mental health domain reminds us to ask patients what their day-to-day mood is like, things that might impact how they're able to manage their health conditions.
If I have somebody who has diabetes and I haven't delved into their depression, that's a barrier to self-care. So the HNP 360 is a tool to enable you to really see the patient for not just their biomedical condition, but beyond that.
And I think that by making it systematic yet still flexible, you can catch things that would have gone unnoticed.
When you teach the students this from the beginning, then all the tools are there.
The HNP 360 has been tested and used in numerous different settings: inpatient, the outpatient, household-centered care, and telehealth. And it has been found to be helpful by both faculty and students alike.
It was like lights were going off. It gave them a way to navigate this complicated roadmap.
They learn more about their patients. Their patients feel that their physician or their student is very engaged in what's going on. So we have implemented this into our clinical skills curriculum. And this is the only history and physical that we're teaching.
It develops a common language for educators to start talking with their students about critical domains, and gives educators a better sense of being kind of comprehensive with their patients. So at the end of the day, the HNP 360 is designed to be a simple roadmap and reminder to busy clinicians about the different aspects of patients' lives that ultimately determine not just their health outcomes, but the outcomes of their communities as a whole.
So I do enjoy what they have accomplished here. and I integrate their work into our medical board. And I went beyond that, and we have this four domains uh, for management and treatments. And diagnosis is to consider the redox, metabolic, and immune regenerative and what disturb it, and how to monetize it, and how to assess it, and then how to modulate it and restore it back to normal, or modulate it to kill the infection or kill the cancer. Um, and those are in a form of 15 modules that it's going to be the fellowship program. Hopefully, we're going to put in 100 hours, and it's going to be structured, because I can see this alternative medicine or regenerative medicine or anti-aging. It's a field that's not well structured. It's like a wild horses. And we need to come up with an organizing this field. We come up with a textbook, curriculum, protocols that will standardize. It's still personalized medicine, but at least you have the logarithm and the language to how to approach those patients. And all those 15 modules is based on those four domains. And when we go through them, you can see, for example, here the module number one is basically um, taking physical and history, taking the physical and history as American Medical Association is entertaining, is to include those seven or six domains that they have, or seven domains, to be more comprehensive, including all the systems of the body, and including all the environmental stressors and psychological stressors that may aggravate the current conditions. And so we are adapting the HP 360 in our patient evaluation strategy, the same thing that the HP or the CDPM group of the AMA, which we call it HP 360. So, for example, 60 years old women experience hypertension and persistent fatigue, undergo an in-depth assessment, including their genetic analysis and endothelial function evaluations, and you take all the history and physical exam and seeing all the factors that aggravates the patient's hypertension. Maybe she has leaky gut, maybe she has toxins, maybe she's not eating well. Maybe she has deficiency of vitamins. So all of this needs to be included. Maybe she's drinking too much of alcohol. Maybe she's taking drugs. And so and looking at all different systems that aggravate those conditions that cause more insulin resistance. If you have leaky gut and you have lipopolysaccharides, which are free radical generators, they will oxidize the insulin receptors and cause aggravation of your diabetic, and you need more medications. But instead of giving just insulin and adding more insulin, because insulin itself is free radical generators, with time it will cause more insulin resistance and then you need more dose. That's what the mainstream medicine does. No, we want to really come up with increasing insulin sensitivity. Now, we can do it with metformin, but also we can do it with polyphenols. We can do it with low carb diets, because we know glucose itself is a free radical generators, which will lead to oxidation of those insulin receptors. So we're looking for anything, all those free radical generators that oxidize, that further oxidize the insulin receptors. We need to eliminate them. We need to screen them. Could be mycotoxins, could be Lyme disease, it could be rheumatoid arthritis. So we need to be more. It could be stress. Patient has stress at work, at home. It could be he's drinking too much. Um, Family problem. He has no money, and all those stresses and all those factors can definitely lead to oxidative stress and aggravate the current conditions. And we need to tackle all this root cause and try to reverse it instead of just giving them insulin more and more. Because when you give them more insulin, insulin itself is a free radical generator, which causes more insulin resistance, and then you end up with the patient is taking the highest dose of insulin, it's not working, and then all this damage that's going to happen from the oxidative damage from the blood vessels because of all this free radical generators and oxidative stress will lead to all this neuropathy, angiopathy, and then amputation and gangrene, all that stuff. So we really need to come up with the real approach of this is to take complete physical history exam and look all screen all the stressors and eliminate them, in a state of just giving them hypertensive drugs and insulin, which you continue giving them, but we want to wean them from those drugs because all those drugs, big pharma drugs, their metabolites are not biologically friendly, and they can be a source of free radical generators, including metformin, by the way. Um, Metformin can interfere with vitamin B12 absorption and metabolism. And so we need to look for a natural way to enhance the antioxidant expression epigenetically using polyphenols, TOs, low carb diet, healthy food, balanced food, exercise express antioxidants, and neutralize the free radicals, looking for the gut microbiome, looking for the toxins. So it's going to be more comprehensive here, management and getting and screening all those free radical generators and eliminate the root cause instead of just dumping them with hypertensive drugs and insulin. And that's what they do in the mainstream medicine. Just prescribe them. And if you do the root cause and you eliminate all those root cause that causing damaging to the blood vessels, that causing damaging to the endothelium, and you improve the endothelial cells function, you will improve the hypertension, where you don't need to have those much of big pharma products. You can wean patients from the hypertensive drugs. I'm not saying stopping them, but you can wean them, and you can wean them from the insulin. And with time, some patients they end up free from insulin or free from hypertensive drugs. By the way, some of patients they don't need it anymore if you optimize their weight, you manage their estrogen dominancy, their cortisone dominancy with all this integrative approach that we talked about, restoring the redox, the metabolic, the immune, and restoring the regenerative status of the patients. Those four pillars, if you apply them, you definitely may be able to completely wean them from their mainstream medicine drugs. So the next module is gut health, and it's very important, the gut health, because we know that those bad microbes or bad bacteria in the gut, they disrupt the barrier, which is the gut barrier, those tight junctions and between the endothelium, and they cause them to become leaky. Leaky for what? Leaky of the free radical generators. Free radical generators of what? Of liposaccharides of the bacteria especially, but all the toxins. And they will start seeping into the blood. So those liposaccharides are free radical generators. They will cause inflammation in the gut. And inflammation, constant inflammation of the gut can progress and become irritable bowel syndrome, by the way. So inflammation and constant irritation of the visceral fibers and visceral pain can also cause some sort of progressive neuroplasticity and reflex of sympathetic and parasympathetic, and that can cause what we call irritable bowel syndrome. Those free radical generators also, as being leaked, can go to the brain and cause microgliosis, inflammation, and cause leakage of the brain. Blood-brain barrier will become leaky. And then all the toxins will go in the brain and cause inflammation. Inflammations can lead to enhancing the progressive neuroplasticity that's caused by inflammation of the gut, which will cause irritable bowel syndrome to become even worse. And then those free radicals also, they can damage the autonomic neuropathy. And that's the reason when we have irritable bowel syndrome, some of them are constipated dominance, especially if their free radicals is damaging their parasympathetic and they have overactive sympathetic, or they can cause diarrhea dominance irritable bowel syndrome when the free radicals damaging the sympathetic part. So you have abnormal autonomic nervous system response. You have this progressive neuroplasticity was causing this abnormal autonomic nervous system overactivity or down activity because of or they become dysfunction because of the damage directly from the free radicals, and you will end up with this autonomic abnormality in the form of irritable bowel syndrome. It's part of it's neurogenic, inflammatory, sympathetic overactivity, and sometimes parasympathetic overactivity if sympathetic nerves is being damaged by the free radicals. And some of the irritable bowel syndrome is a mix between constipation and diarrhea. Now, the mainstream medicine, when they're gonna manage this, they just give them an anti-diarrhea drug or anti-constipated drugs, which is the laxative or that's what they do. They mask the problem, or they give them this neurolytics, a neurotrop, those ones that numbs the nerves, instead of going to the root cause, which is managing the leaky gut by normalizing your microbiome, by getting rid from those pathogens that causing the leakage in the beginning. And that's where we are better in than the mainstream medicine managing irritable bowel syndrome. We look at restoring the microbiome and eliminate those pathogens that cause the leakage of the barrier of the gut, instead of just masking the problem with all those drugs that works on the nerves and numb the nerves, and numbs your autonomic nervous system. Far there. Um, so we call them neurolytic drugs or whatever, and instead of going to the root cause and manage the leaky gut itself by restoring the microbiome balance. And you do that by giving them probiotics, prebiotics first. I like to give them prebiotics so you can feed the healthy bacteria and kill the bad bacteria. Once you feed the healthy bacteria secretes postbiotics like butyric acids, and butyric acid itself can be killing the bad bugs, but also butyric acids helps to decrease inflammation, especially TH17, and also it helps to stimulate the healing and the tight junction connections and regeneration of the gut epithelium. Um, so you give them prebiotics like aloe vera extract. Um, Ivermectin, by the way, it's a prebiotic, by the way. But you give them aloe vera, um, and you can load inside cyclodextrin if you want. Um, and you can also give them butyric acid, by the way, and load them inside cyclodextrin. That's the reason I put the cyclodextrin book here, that we can load drugs inside cyclodextrin for slow release and stabilizing all those drugs. And then after 1 week of prebiotics, then you can, after you kill and you nourish after you kill the pathogens and you nourish the healthy bacteria, then you say, okay, I'm going to give them now probiotics to replace and replenish what's been destroyed, and normalize the balance of all this variety of difference of normal bacteria or gut that has synergy, some biotics with your gut. So those normal bacteria, they don't cause damage to your leaky gut. They don't cause damage to or cause leaky gut or damaging to the tight junctions. But there's a symbiotic kind of a mutual benefit between the gut and the bacteria. In addition, that those bacteria produce hormones and vitamins like vitamin K and other neurotransmitters, building blocks that we needed for our brain functions. Um, so tryptophan and other things can be metabolized and can be produced by the gut bacteria. So it's very important. And if you understand here that with restoring the gut microbiome, what I did here, I actually worked on those four pillars. I restored the immune balance because I inhibit the TH17 and inflammation of the gut by butyric acid that's produced by those normal healthy bacteria, right? Do your probiotics especially. Okay, so butyric acid. And I restored the metabolism because all those bacteria also produce vitamin K and other nutraceuticals and building blocks, especially for the neurotransmitters of the brain. So I'm restoring the metabolism. I'm restoring the redox because once I heal the leaky gut, then I don't have much of leaking of toxins, which we call them the free radical generators, right? So I'm balancing the redox and also those redox or free radicals, the liposaccharides, which cause inflammation of the brain and all other parts of the body and aggravate your existing conditions. If you have diabetic, it gets worse. If you have hypertension, it gets worse. Rheumatoid, it gets worse. Alzheimer, gets worse because of those free radicals causing inflammation, especially the TH17 overactivities. Well, by normalizing the microbiome and stopping the leakage of those free radicals, I am also restoring the immune balance. So I'm working on those four fields, and if I do that, then I will definitely help in regenerating the body, right? If you end up decreasing all this inflammasomes and all those free radical irritants that actually causing degeneration, then you will end up normalizing automatically your regenerative. So by using gut, I mean restoring the leaky gut and managing the gut health, the four pillars is it's automatically. The main pillar that is working that we need to emphasize is restoring the redox. I mean others, yes, but most importantly is the redox balance that's coming up from balancing the gut. I'm not saying, restoring the metabolisms and is not part of it, but the main part. So gut health and what we're doing, we definitely help to balance um, specifically the redox balance. And because all those free radicals generators will be neutralized by blocking the leaky gut, by healing the gut endothelium and the tight junction, and preventing those toxic lipopolysaccharides from those bad bacteria from leaking in, because they are the free radical generators. Okay, so module number 2 is integrative immunotherapy, is to balance the immune system. And this itself, we can create a book here with gut health. We can have a book for restoring the gut health as a subspecialty. So if each module we can create a book. I like the lecture of Dr. William Clearfield on gut health. He have a very big lecture. So possibly me and Dr. William Clearfield, we end up having a book on gut health, just gut health, just restoring the gut health, and we're going to have a book for that. And Dr. William Clearfield have a very nice lecture on it. We can take the material from him in addition to my material, and we can create a book with our editors and with the help of the AI. It can be done in 2 weeks. That's how fast the AI is generating books. But I'm open for anybody here in this room. If you're interested in co-authoring any book with me, that will be a good thing to do. Now, immune imbalance and restoring it to manage chronic diseases. Most of the time, and most of the doctors, they are doing good in restoring metabolism and redox. And when I say metabolism, including hormones and peptides and all that. And they're good in maybe restoring the detox by the diet, involving in healthy diets and antioxidants. And we're doing very good in that. Possibly we're doing very good in regenerative by giving exosomes and stem cells. But when it comes into immune balancing, this field is yet, most of the doctors are not mastering it. And it's very, very important. As you saw when I worked with Dr. Also, we are able to manage allergy by shifting the immune system from Th2 to Th1. And this modulation and shifting and understanding those Tregs and Th1, Th17, and Th1, Th17, Th2, those 4 things, of polarizations, it's very critical, because once you understand it, then you can have better management of chronic disease. And there is a lab, regardless of the name, because it's CME here, that they do lymphocyte mapping, cytokine profile, and they do chronic infection panel. And Dr. Joseph James and I were mastering this field, and it does help us to manage chronic disease. Without balancing the immune system, you're managing chronic disease 50%, and you have 50% still in the dark. But once you have the clear understanding of the immune status of the patient, whether it's Th17, Th1 dominant, or it's Th2, and some of them Th2, Th17 dominancy, then you can understand how to shift the immune system from Th1, Th17 to Treg and Th2. This is in case you have autoimmune disease, rheumatoid arthritis, or you have multiple sclerosis, you want to shift the immune system from Th1, Th17 to Treg and Th2. If you have allergies, then you want to shift the immune system from Th2, Th17 to Th1. And you can do that with supplements. You can do that with peptides. You can even do that with drugs as well. And I can help you to develop those lists of drugs and supplements. With the use of the AI, and then we can create it through a compounding pharmacy, a cocktail formulation personalized for that patient to modulate the immune system. This is a new field of medicine, and I'm trying to integrate it in our protocols. I'm trying to get the doctors on the board with us so they can adapt it, because once you have understanding of immune modulations and how to modulate it, you will feel more confidence about managing any chronic disease, including cancer. In cancer, you want to modulate the immune system, polarize the immune system, especially in the cancer area, not everywhere, to Th1 and cytotoxic T cells. And you can do that with antibodies, blockade, those immune blockade drugs that helps to block the Tregs and polarize the immune system to Th1 cytotoxic T cells, anti-PD-L1, anti-CTL4. You know, we can help you with that. But those drugs, those antibodies, if you inject them nakedly, they go everywhere. The mainstream medicine, they do it, the immunologists. They go everywhere to the cancer tissue and also to the healthy tissue, and they cause problem in the healthy tissue because it will lead to autoimmune diseases, or it will lead to immune system. The Tregs will be inhibited, which helps to desensitize your body against your self-antigen. So it becomes sensitive. You end up with colitis and possibly other autoimmune diseases. Um, and that's the reason that in our approach is to load those antibodies inside platelets nanoparticle, possibly complex it with PLGA or cyclodextrin, and then load inside platelet nanoparticle so you can get those antibodies into the cancer tissue only instead of going to the healthy tissue, and only cause inhibition of the Tregs and shifting it to Th1 and cytotoxic T cells of the cancer versus going everywhere. Because if it goes everywhere, sometimes this immunotherapy can cause a flip, can cause actually more problem. Why? Because if you start activating the immune system in the healthy tissue, then you drain the immune system, you exhaust it, and then you don't have much of Th1 cytotoxic T cells in the cancer area to kill the cancer. So it's very important to be efficient here. And how you do efficient? By targeting therapy, by learning how to do platelets nanoparticle, and also working with those compounding pharmacy who are developing cyclodextrin loaded drugs or loaded antibodies or loaded chemotherapy or loading anything, peptides, for example, thymosin beta, for example. You can load inside platelet nanoparticle and getting into the pathology versus going everywhere. And you can get better results doing that. Or thymosin alpha, you want really polarization more in the cancer area versus going everywhere. So I give you a case here about 28 years old women with chronic eczema, asthma undergo allergy testing, revealing sensitivity to common food items and dust mites. Immunotherapy, which desensitization. How we do that is by polarization of the immune system into Th1 um, from Th2 to Th1. And we can do that with skin prick, desensitizing, because that skin prick, possibly those macrophages, dendritic cells, in the skin, they will polarize mainly into Th1 instead of Th2. But we can also do it genetically by loading those plasmid into platelets nanoparticles, or the messenger RNA was expressing those peanut allergens, and load them inside platelets nanoparticle and then inject them into the body, whether IV or just under the skin. So that's what we do. We shift the immune system from Th2 into Treg or to Th1. And also you can use supplements that helps to polarize the immune system to Th1, like omega-3 supplements, curcumin, and many other things. Thymosin alpha, again, that's a peptide, or may help as well in shifting the immune system to Th1. Module number 4 is environmental toxins. And definitely we can create a book on this. Maybe Dr. Joseph James or Dr. Bennett would like to join me in that, or Dr. Dalal, and we can create a book for immunomodulations and immunotherapy for all immunotherapy for all chronic diseases where you have immune imbalance. Most of them they have, but specifically the autoimmune, the allergies, and also cancer. Cancer, you want to modulate the immune system to Th1 and cytotoxic T cells, because the cancer are a very, very intelligent creature. They secrete chemicals like interferon and interleukin 10 and transforming growth factor beta, and they lead to polarization of the immune system into Th2 and T17. And if you polarize the immune system into Th2 and Th17, what you will get? You will get neutrophils. Neutrophils will not do anything with the cancer. You get antibodies. Antibodies will not do anything with the cancer. You really need to restore them back, balance the immune system, move them to Th1 and cytotoxic T cells. Because cytotoxic T cells will grab the cancer and create holes in it by secreting those perforins and blow them up. You cannot do it with neutrophils. You cannot do it with antibodies efficiently. You really need cytotoxic T cells. So in cancer treatment, you need to shift the immune system into Th1 and cytotoxic T cells and change the tumor microenvironment from being friendly with the cancer and protecting the cancer because they'll be surrounded by Tregs into a hostile environment where they would have active cytotoxic T cells killing the cancer. Module number 4, which is environmental toxins. And environmental toxins, I will do up to 7 modules, and then we do another sessions, maybe, and we're going to split this into 2. So I will do 7, and then I will do the others in the next meeting, so we can have chance for us to have a conversation here. But toxins in general, they are free radical generators. So when I am restoring or detoxing the body from those environmental toxins, whether it's fat soluble toxins or water soluble toxins. Water soluble toxins, those heavy metals, calcium, mercury, all those things, copper, sorry, calcium, lead, all those heavy petrochemicals, which are all fat solubles, xenoestrogens, all that. We're living inside a bubble of petrochemicals and plastic and microplastics. And we need to work on detoxing the body from it. And detoxing it by avoiding it, first of all, from exposure to it, by changing our habit in food eating, making sure they're free from all those xenoestrogens and organophosphorus and pesticide and all that stuff. And then we need to work on removing them. And we can remove them by using those chelations or sweating in the sauna. That's natural way. Or by chelations. And the ADTA can only work on water-soluble toxins and heavy metals, but they don't do much in fat-soluble toxins. So the solution either is sweating, that's what we know, or the new solution is cyclodextrin. Cyclodextrin helps to detox the body from fat-soluble toxins, organophosphorus, microplastics, pesticides, and all those toxins that's been released from the fat tissue, especially when you do weight loss and when you use Ozempic or BLG1, and the patient say, I don't want a BLG1, it's causing me sick. The reason it's causing sick, because once it's effective and you start reducing fat tissue and shrinking, your fat tissue start releasing those toxins, and those toxins will go to the liver and irritate the liver, cause inflammation, cause irritation, and that's why you feel nausea and say, I don't want to take this. But if you detox the body with cyclodextrin loaded ETA IV, or you load those PLG1 inside cyclodextrin, so you have 2 birds with 1 stone. You're shrinking the fat with PLG1, and then you're detoxing your fat soluble toxins, which is those petrochemicals and organophosphorus, which can cause shutting down of the organs. It's very important to detox the body while you're doing weight loss. And that kind of nausea, in some people they say this is side effects. Actually, it could be a protection. Because if you're taking GLP-1 and you don't detox, and we don't have any signs of those toxins like nausea and vomiting, then you may end up with organic failure. So your body is warning you, say, hey, yeah, I have toxins here. And so how you manage weight loss in this case, you give them IV cyclodextrin, you put them in a program of sauna, you give them antioxidants, you trying to detox the body while you are doing weight loss with your PLG. And if you don't do that, and you give them also nutrition, vitamin B12 and thymosin beta and other things that helps in decreasing the inflammation. Because those toxins, they cause inflammation and they cause imbalance in your immune system. So from redox imbalance, which is those free radical generators, those toxins, right? Whether it's fat soluble or water soluble toxins, into imbalance in the immune system, into inflammation. And that inflammation and senescent cells, inflammasomes will interfere with your regeneration and cause degeneration, right? And eventually, those inflammation, especially in the gut, may lead to malabsorption, and you will end up with problem with your metabolic. So one leads to other, right? But it starts with redox here. So I like to put environmental toxins as under the domain of redox, but it does not mean that because they all overlap. All lead to others. But the main thing is really it helps to balance the redox. So 42 years old factory worker with chronic fatigue and neuropathies diagnosed with heavy metal toxicity. What we do chelation therapy here, and we combine nutritional, zinc, selenium. All of this helps to improve the expression of antioxidants, working on your epigenetics here, and helping in neutralizing those source of free radicals because they are source of inflammation and degeneration and metabolic disturbance and aging and disease and death. Okay, so what will be the other modules? And each module we can create a book. We can create environmental medicine book with Dr. Patel Kalpana. She's a specialist in that. And she has very nice art lectures, so I'm going to reach out to her. She's not attending today, I don't know why, and we can work on that together. Then, very important is latent infections. You know, those Lyme disease, those Epstein-Barr virus, and all that hidden infections that we've been exposed, and COVID, all those, you know, they can herpes. We need to get rid from them and neutralize them because they can be source of free radicals. So they are free radical generators. But also, when they are free radical generators, they can also lead to inflammation. So you have immune imbalance, right? And inflammasomes means what? Degeneration. And all of this can lead to metabolic disturbance because it may lead to abnormal absorption of your food when you're inflamed, or it will interfere with metabolism when you have oxidative stress, right? Um, because it will block the enzymes and it will block your, so one leads to other. But the main thing, this is more of redox balancing. And then the second part is inflammation. So how we manage this patients? Um, we help to get rid from those bugs. How we get rid? We can use antibiotics, but antibiotics they develop easily resistance. So how I can override the resistance is loading those antibiotics with cyclodextrin. Again, cyclodextrin book, which I wrote this book and I put it in every chapter. But hopefully we will have an environmental book as well, medicine book, in addition to cyclodextrin book. And cyclodextrin is involved in everything here because we want to load those antibiotics with cyclodextrin. When you load it with cyclodextrin, you can break the resistance. The when because then with cyclodextrin nanoparticle or cyclodextrin antibiotics, cyclodextrin itself will help to break down the membranes of those bugs and those viruses. So itself it's an antibiotic, cyclodextrin. And then it finds a pathway for the tetracycline antibiotics to work and bypass whatever it's being blocked or resistant to. Maybe the entry pathway it's being changed, and that's why the antibiotics cannot get inside the bacteria. With cyclodextrin, you can bypass that. Okay. What other things you can do? You can do methylene blue. You give them to the patient, IV 20 milligram or up to 50 milligram or oral. And then you put them in ozone and light therapy, and it's called photodynamic therapy, right? And I'm trying to create a system where you have light and ozone or light to an oxygen chamber at the same time. So you empower all the components of photodynamic and destruction of those bacteria. And then you put them in, after you give them IV, 20 minutes, maybe 1 hour. Then you put them inside the chamber of oxygen and light therapy so you can activate the photodynamic therapy. The photosensitizers, methylene blue, generate free radicals. It will take by those oxygen, generate free radicals, and those free radicals will eat the bacteria and kill the bacteria. So that's one way of detoxing or getting rid, eliminating, eradicating those chronic infections, whether it's bacteria, virus, name it, COVID, right? Yeah, and you can use the, Macala protocol, nattokinase, bromelain, curcumin, methylene blue, ivermectin if you want to add, um, in the mix of managing COVID if you want. Module with clinical, the other module, which is number 6, is restoring the metabolism. So when I say metabolic health, don't be confused. It's just it's not only a metabolic syndrome, which is obesity, hypertension, diabetes, and high cholesterol. No, the whole metabolism of the body. Restoring the whole including 6 hormones, including the nutritional deficiency, including the epigenetic function, is restoring the metabolism back to normal. So it's replenishing your six hormones, your hormones in general, your peptide signaling, it's replenishing anything that's part of your endogenous chemistry and restoring the chemistry. Or any drugs that's out there that helps to restore the chemistry of the body to normalize it, it's considered restoring your metabolism. What's it? Vitamin deficiency, give them vitamin D, B12, folic acid. Some people have homocysteine methylation problem. You start overriding it by giving them folate and something like that. So restoring sex hormone is very important, especially with weight loss. If you do weight loss and you don't normalize the sex hormone, you're wasting your time. Because if you lose weight with GLP-1s and you even use cyclodextrin and you detox the body, and his sex hormone is outside the chart, abnormal, that's meaning male has low testosterone and all the testosterone is being converted to estrogens for some reasons, whether it's being the aromatase is being active by the toxins in the body. Um, and or patients is obese and have a lot of fat tissue to aromatase those testosterone. So you need to do both, weight loss and balancing the sex hormone. And the reason because when you aromatase and you turn the testosterone into estrogens or estradiol into estrogens, right? Those estrogens are inflammatory and proliferative and carcinogenic when it's excess, especially when you see the ratio between estrogen and estradiol above 2. That's a problem. In female or male, that's a problem. You need to get it below that because estrogens is inflammatory and it also stimulate the conversion, activation of the cortisone into cortisol. And it leads to estrogen to cortisone dominancy. So from estrogen dominancy into cortisone dominancy. And we know when you have cortisone, too much of cortisone, it will suppress your immune system and it will activate your sympathetic overactivities, and you have this vicious circle, and it leads to oxidative stress and more inflammation. And more inflammation means you have interfering with the mitochondria, the fat cells, and you have problem with burning the food, and you have more deposit of fat tissue. So it's not so it's very important to eliminate those excess of estrogens by normalizing your sex hormone, by blocking those aromatase. And you can block them by giving them progesterone intranasal. That helps to feed the sex hormones, the testosterone, and block the aromatations, and also counteract the estrogen effect, especially the estrogen's inflammatory and proliferative effect, which can lead to cancer. So if you can see estrogen excess and xenoestrogens is the reason why we have prostate cancer, colon cancer, even lung cancer, and all the prostate cancer and breast cancer. And we need to figure out how to manage and balance the sex hormone and inhibit the estrogens. And estrogens, these two also, as I said, it feeds and activate the cortisol and turn into cortisol. They become active. And then the estrogen dominancy feeds the cortisone dominancy, and cortisone do suppress, especially the Th1 and cytotoxic T cells, which put the patient at risk of viral infection and cancer. So patients who are obese and overweight, they have high risk of cancer and infection of virus. So when you're trying to help those patients, you tell them, hey, those fat tissue is the problem. And I think in the future that we will see fat tissue, excess of fat tissue, it's disease. And we will see the primary health care when you see patients overweight, it's like, okay, this is cancer inflammation and we need to work on it. It will not be normal anymore for the doctor. He will see it as he's seeing cardiovascular disease. He will see it as atherosclerosis or stroke or heart failure, the fat, obesity. And once it become recognized as a disease and the doctor's mandate to manage it and the patients and their work and even in the work status, you have to be, you know, fit in order to work. That is going to be that pressure of the society, like we did in smoking, and we stopped it, right? In the public and work environments, then we can have positive impact. I'm not shaming obesity here. I'm trying to create some sort of cognitive therapy to enforce the importance of weight loss. And we have the tools to do that. Before we don't have PLG1s, GLP1s, Ozempic, and that. So there's an excuse. We don't have the tools. Now we have it. Really, you don't have any excuse to have an extra fat today. Anybody has extra fat today. And I think that's where RFK is working on that. And actually, he's working on a way that he wants to provide GLP-1 by insurance and mandate it. And it's going to be part of our treatment. That's the main thing. When you see somebody who's obese, it's like seeing somebody with cancer. This is how we're gonna in the future is gonna be seen. Um, and yes, because if you really get rid from all those fat are storage of carcinogenics, of petrochemicals, of organophosphorus, of xenoestrogens, of aromatizing your testosterone, and then estrogen dominancy, which led to cortisone dominancy. Cortisone, it's an aging drug. It leads to grayness of the hair, aging, it speeds the process of the aging. So it's part of anti-aging to reduce your weight. Part of anti-aging to reduce your weight. And you do that with GLP-1, cyclodextrin, in addition to normalizing the sex hormone. This will be the last module, and then we will finish the other 8 modules in the coming lecture, which is next Monday. So we're going to have part 1 and part 2 for chronic disease prevention and management. In cancer prevention and management, it's very critical that we understand that the cancer is intelligent creature. And don't be fooled by doctors who are saying, oh, we cure the cancer, just give them ivermectin. Oh, we cure the cancer, just give them methylene blue. We can cure the cancer, just give them keto diet and insulin shots. We cure the cancer by giving them curcumin IV. All of those is a good. They will help to peel a layer or two, but it's not comprehensive. And the word cure cancer it's a foolish word. You don't say cure in cancer, you say remission. Why? Let's say a patient has colon cancer and you induce remission and you remove all the cancers. But okay, but still there's cancer, there is colon tissues. And those colon tissue at any time they can become cancer. You have genetic problem there. And so when you do the remission, you need to change his lifestyle where you eliminate any chance of any carcinogenics. Means that he has to eat healthy, he has to be on polyphenols. You have to do everything to prevent activation of those carcinogenics because he genetically he's all his colon cancer, all his colon tissue is risk of having cancer. So we say remission, we don't say cure. We only say cure if we completely change his genetic makeup, and that's not going to happen. Okay, or you remove the whole colon tissue, possibly, right? Um, uh, we can say for thyroid cancer because I have papillary carcinoma, and we can say we can cure that because if you remove the whole thyroid, there's no thyroid tissue anymore. Yeah, there is no chance for because there's no thyroid tissue. But for other thing like breast cancer and you just remove the lump and you have breast tissue still from another side, that breast tissue can turn into cancer or any other tissue that's you're unable to remove it completely. That's mean you still have a risk of having cancer. So that's very important. The other part is very important is to know the cancer is intelligent creature. And we have all the tricks to fool your immune system, to change the tumor microenvironment and his and the best and in a way to favor the cancer growth. So let's give you an example. Cancer secrete chemicals that polarize the immune system from Th1 to Th2 and Th17 and Treg. So there's not much of Th1 cytotoxic T cells. And that's what cancer does. It secretes interleukin 10, transforming growth factor beta, and other chemicals, and even make the environment of the cancer acidic to turn those cancer cells into cancer stem cells, de-differentiation into cancer stem cells by acidic environment. And the acidic environment also helps to polarize the immune system to Treg. That's one thing. All right. So I have a problem with doctors saying, oh, so it is acidic. Let's go ahead and drink alkaline water and help that cancer patient. Oh, that's a fool. Yeah, because when you drink alkaline water, it gets into your blood will buffer it. There is no way it will help the cancer. Your blood is very strongly buffered. So that, oh, let's drink alkaline food and drink milk. Milk is alkaline, for example. No, that's not going to work. That's not alkaline food. That's not what alkaline means. That's not what alkaline of the cancer means, is to drink alkaline food or drinks. So what is alkaline food? Alkaline food is the food that activate the mitochondria and shift the lactic acid into the Krebs cycle. If you do that, then you turn the tumor microenvironment into normal or alkaline. So what is the food that alkaline the tumor, right? Not alkaline food means drinking. You take the food and you measure the pH, and if it's above 7, then that's a good for cancer. No. Yeah, you eat food that helps in activating the mitochondria. Polyphenols does that, right? The polyphenols, which is the flavonoids, quercetin, ECGC, all of this helps to activate the mitochondria. Anything that activates the mitochondria will help to shift the lactic acids into a Krebs cycle and break it down. That helps to decrease the tumor acidity, and helps in also shifting the Tregs into Th1, and helps in preventing the dedifferentiation of the cancer cells into cancer stem cells. So that's what we do. That's means alkaline food, okay? Because there's a lot of misunderstanding of doctors, and I met with those doctors, and I think Dr. Dela knows them. And I told them, what you're doing, it's not the way that you're presenting, it's not right. Okay. The other thing is that you need to learn how to modulate the immune system to Th1 and cytotoxic T cells by knowing the peptides that polarize the immune system to Th1 side, like thymosin alpha. So if people does not know the polarization of the immune system, they're giving thymosin beta to patient of cancer. That's a crime. Why? Because thymosin beta will polarize the immune system to Treg and Th2 and make the cancer more worse. And that's why the FDA will go after those doctors. Lack of understanding of the mechanism and the chemistry of peptides is the reason why the doctors get in trouble. That's why we are providing them an education platform so they can understand why we're using thymosin alpha versus thymosin beta when we're treating cancer. Because it polarizes to Th1 cytotoxic T cells. And there's a lot of supplements who does that. Curcumin, quercetin, ECGC, they help in polarizing. So this is one. The other part of cancer. Okay, you have fibrosis. Do you see those cancer? They have fibrosis, and and they squeeze their blood vessels. Why do they have fibrosis? They secrete interleukin 6 and transforming growth factor beta, which stimulate the fibrosis, the fibrosis of the cancer. And they secrete, they produce fibrosis and squeeze the blood vessel. Now, if you squeeze the blood vessel, what will happen? The cancer is getting food, the sugar, all that, it will pass, but the lymphocytes and cytotoxic T cells will not, because they're being squeezed. So the cancer is trying to block lymphocyte infiltration and killing the cancer. See how much smart? So what you will do, then you need to give them antifibrosis, Clotho, losartan, and many antifibrotic drugs that we know. What other thing? The cancer is making the blood vessels tortuous and kinky. So that helps them, and when they come kinky, it prevents the lymphocyte infiltration, right? And so they end up secreting VEGF. And VEGF also helps in polarizing the immune system into Treg. Two birds with one stone. See the cancer? So what you need to block that by giving Avastin. Okay, what other things? The cancer is secreting chemicals that causing platelets activation. And platelets form a shield around the cancer, preventing the cancer to be recognized by the immune system because they're protected by the platelets. So you need to give them antiplatelets like aspirin and things like that. Okay, what other things? If you want to do the chemotherapy, use low dose chemotherapy, activate them with light, and target it with platelets nanoparticle cyclodextrin. Load them inside platelets nanoparticle cyclodextrin so it does not go everywhere. So you can use low dose. Okay, what other things? Well, use immunotherapy, anti-CTL1, anti-PD-L1, anti-CTL1, CTL4, anti-PD-L1, and load them inside platelets nanoparticles and give it to the patient. So you don't give nakedly antibodies like immunologists do, where they activate the autoimmune and immune system in healthy tissue, which you don't want because that will drain the immune system. You need to target it into the cancer, loading them inside platelets nanoparticle, and you get them into the cancer. That's the reason why we need to practice. If you're integrative oncology and you're not doing platelet nanoparticle, I'm going to tell you, I'm sorry, you are behind the curve and you're not really completely managing the cancer. You can do good with your metabolic approach, with all the nutrition and all that, and ivermectin, which interfere with the metabolism of the cancer. Yeah, you can do, but you don't have the comprehensive approach to tackle the cancer from A to Z, including targeting nanotherapy. And we have the training, right? So we need that to be on the board. And so, and then after we get rid from the cancer, we need to learn how to prevent it. We need to do some pharmacogenetics or cancer genomics and see how we can prevent the cancer from coming back by giving them polyphenols. Let's say, for example, patient has risk of having cancer by the genomics studies. Okay, so what I will do, put them in the right diet, give them excess of polyphenols in his diet. So that helps, as you know, in keeping the immune surveillance strong, because this polyphenols help to polarize the immune system Th1. And also you need to optimize the health, looking for any um, free radical generators, estrogen dominancy, obesity, looking for mycotoxins. All this needs to be cleared for those patients, because all this can really trigger the cancer. So you need to health optimize that patient. If especially if the cancer, if he has genomic that shows that he may have cancer. And once we treat the cancer, then you need to prevent it from recurrency, because most of the cancer, you did not remove the whole tissues, and all those tissues, let's say if you have colon cancer and you don't remove the whole colon, the tissue that of the other colon that you think it's healthy, they can become cancer. So those patients needs to go into rigorous preventive measurements, and optimizing their health and making their immune system strong, and they need an extra step. And yes, it costs too much money, or it costs money to make those people to survive longer. Eventually we're gonna all die. But if you add 1 year, 2 year for those patients, it's for his age, that's a success. Even if you add 6 months, right? Because eventually we'll all die, and what we are doing on this earth is just expanding the time we are here up to 100 years old. That's the max, and maybe 150. Dr. Klatz is very optimistic. He wants to go to 150, which we try to do that. But in order to be optimistic here, in order for you to reach into 150, you really need to optimize your health. You don't need to have you're supposed not to have any extra fat tissue in your body, and you need to remove all the toxins in order to add more age to your time. And max you can go to 150, and you cannot go beyond that. The reason, because we are genomically programmed to age and die. Maybe since this is theory, not evidence, since Adam ate from that tree that's been prohibited, God maybe create us immortal. We have immortal genes that not corrupt up to now since Adam, and we call them immortal genes. You can Google that or PubMed that. But a lot of genes is being corrupted, and the corruption is increasing with the generations, and that's why we're expecting the lifespan will be shortened if we keep with all these toxins and all these mutations that's going to be increasing in number, and that our lifespan will shrink into 10 years and maybe 5 years, and maybe that will terminate the human race. And but if we start doing the health optimizations, all of that, we may be able to slow the clock of the epigenomic part of the aging, not the genomics. In genomics, you need to change the whole genomic makeup, which is up to now, we don't have the technology for that at all. So I think we're good. I still have 15 attendees from the 19, so 4 is missing, which is good, you know. Um, we will finish the whole thing, all modules, the other 8 in the next meeting, next Monday. But from here to there, we can ask questions if anybody has questions. Questions? Any questions?
Yeah, Dr. Halassa, real quickly, another brilliant lecture by you. Are each one of these topics designed to be a book? I think I missed that part.
Yes, each of this module. So we have chronic disease prevention management, which is the Bible of everything.
Right.
It's a big
Right,
text. I will thank Dr. Benoit
Tano, yeah.
here, Benoit Tano. He put together, and we have a big Bible. But then we need to come up with those subspecialty books. Um, so I have a lot of doctors interested in doing that, and we can do them. They can become co-authors. But some people are more into this specialty, like metabolic. We can give it to Dr. William Clearfield because it's very good. Tano, we can give him the environmental toxins and a book of estrogen dominancy. He's very good in that. Well, whatever. If you want to go involved in any of them, you reach out to Sheldon. He's the chief editor, and his friend, his buddy Jeremy, both they work together, and they're editors. And because of artificial intelligence and technology, we don't need to stay 5 years to generate a book. That's an old book, old style. You can generate a book in 2 weeks with the teamwork, with the editors in the board, with the doctors can scan the whole thing, and we can create a book in each module, and even more. In each module, you can even create 3 books under that, and we can create a library, and that's what Dr. Tano is interested in, and then we can do it in Amazon. We can do it under the count of CDPM, and I like Amazon. Why Amazon is better? Let me go ahead and close the recording here.